Hi, everybody, and welcome to the CMH Family Medicine Top Tips and Tutorials. I'm Dr. Muller. I'm a family physician here at CMH. And in this top tip, we're going to look at diagnosing diabetes in the asymptomatic patient who has a random increased HTT at screening. And so this is typically that patient who arrives at your clinic. Maybe the nurses has done a random sugar on arrival, and it comes with that little red circle around it. And how do you now decide this patient has diabetes and I want to start them on treatment? So firstly, who should we be screening in the first place? So ideally, any patient who has obesity or at least one other risk factor for diabetes, we should be doing HTTs, but actually the GEMSTA guideline does recommend that everybody over the age of 45, we should be taking those routine HTTs at our clinics. And I think nurses are actually very good at screening our patients, and so we quite often find patients where that sugar is higher than normal. If you have a symptomatic patient, it's actually quite easy. You only need a single test, and we're all quite aware of those values. So you either have a fasting sugar that's over 7 or a random sugar over 11.1 if you're posh enough and you can do one of those glucose tolerance tests and feed them sugar and then check 2 hours later. You can use that 11.1 there. Or if you've got, for example, you've admitted a patient with DKA, if that HbA1c comes back as over 6.5%, you've made your diagnosis with diabetes and you can happily start treatment. But what do we do with our asymptomatic patients? And those are not so easy. And actually, the rule is only that you do need to have 2 separate tests in a period of 2 weeks of time. So that makes it tricky in the Department of Health setting because our HbA1cs gets gate-kept if we do them less than 3 months apart. So you can't use HbA1c to make a diagnosis. And random sugars, you have to make sure that you actually get that 2-hour postprandial sugar if you want to be absolutely sure you are able to either diagnose or exclude diabetes for that matter. And that means you have to be a little bit more organized. So in our setting, the easiest way to do it is to use 2 fasting plasma glucose. And what I tend to recommend to my young doctors, I think if you're going to diagnose somebody with diabetes and you're about to put them on treatment for the rest of their lives, then you want to actually have something that's written, printed from the NHLS. So what I do is I explain to the patients we're going to need 2 fasting blood sugars. We're going to need actually taken from the arm. And then I give them the lab form, fill in 2 separate lab forms, put in the date for 2 different test mornings. And you can send them either to the clinic or if you have a phlebotomist at your facility, explain to them that they mustn't eat or drink anything that morning. And then they must just go in and have the 2 blood tests done. Obviously, you keep your 2 little barcodes in your folder, and when the patient returns, you will now have those 2 printed results of those 2 fasting blood sugars. This is the table from the GEMSTA guideline that tells you what to do with that result. Very easy. If it's over 7, then that definitely confirms that you've got diabetes. And the ones that are interesting is those patients with what we call impaired glucose tolerance. So if you've done your test like this, you're able to identify people who are where you can't exclude diabetes completely. So under 5.6, we can reassure the patient, but you have patients between 6 and 6.9 fasting sugar that you can see, hold on, you might be at risk of developing diabetes and start bringing lifestyle modification early on. So just before, just in the last little word is once you've now actually started your patient on treatment, you need to decide what your HbA1c target is that you're going to work your patient towards. So you do want to take a baseline HbA1c, and we'll talk a bit more about that when we talk about treatment. And quite often people use the HbA1c to sort of try and adjust their sugars, but that's problematic because you can only do that every 3 months. And we want to get our patients to target as quickly as possible. So you can use your fasting sugar that the patient is going to be taking or your random sugars to actually help monitor your patient towards that goal. And in our setting, that's usually a fasting sugar that the patient gets done as they arrive at the clinic. So what you want to do is once you've started treatment, every 2 to 4 weeks, when the patient comes in, you explain to them they mustn't eat anything before they come to the clinic. On arrival, you do their point of care sugar. And then we're going to use this table also from the GEMSTA guideline to guide us. So in most of our patients, we set a target of less than 7%. And for that, you will have to have morning sugars that is always under 7. And if you are doing a random, that's actually what the 2-hour sugar after the meal should be. It should be under 10. If you've got a young patient or a patient who's quite educated or somebody who's able to well manage, for example, hypoglycemia at home, you can make your sales a bit tighter and actually aim for a 6.5%, which would be an ideal target. And if you've got an elderly patient and you're not really worried about another 30, 40 years lifespan kind of a thing, and you're particularly worried about hypoglycemia, you might make your target a little bit less strict. And you can see those targets only really affect your postprandial targets. It does not affect your fasting blood sugar target. Hope that is helpful. We'll have a next touch specifically on how you get to that targets through your treatment.